and what's very important to know is that the external ear is predominantly formed by what we know as the tympanic bone. Now, the tympanic bone is this wedge of bone that has three suture lines. One is the tympanomastoid suture line, the tympanosquamous suture line, and posteriorly here is the tympanopetrous suture line. So this is the bone that houses both the middle ear and the external ear. Now you see here, this is the tympanic bone. This is the hypotympanic component of the tympanic bone. This is the tympanosquamous suture line, the tympanomastoid suture line. You see how it's important to drill out this part of the bone to get access to the deeper areas of the skull base. I won't. I will go quickly through all these anatomy because most of you are familiar with it, I'm sure. The middle ear and the mastoid. The middle ear can be envisaged as a box-shaped structure with a floor, roof, anterior, posterior, medial, lateral walls. So coming to the surgical anatomy, now you see that the middle ear and the mastoid can be well exposed when we do a cortical mastoidectomy, keeping the posterior canal wall intact, the middle fossa dural plate, the sigmoid sinus, and this is the antrum, which is the biggest of the cells of the mastoid. These are the other cells that you see. You see that some of the temporal bones can be very pneumatic, and you see that there is a good deal of retrosigmoid cells, the perifacial cells, perilabyrinthine cells, and in these cases one has to also, this is the digastric ridge, so you see there's a big retrofacial area here. So decision making becomes comes into play when you have a pneumatic bone like this. As we do a epitympanotomy, keeping the canal wall intact, you first come across the incus, the short process of the incus, the body of the incus, and the includomalial joint. If you're able to get a nice space between the middle fossa dural plate and the posterior canal wall here, you can go further anteriorly, what we call the far anterior epitympanotomy, to go anterior to the includomalial joint to visualize the cog and probably even the supratubaric cells or the recess. Now when the canal is brought down, you see that the facial nerve is seen here. This is the area of the jugular bulb, the lateral semicircular canal, the posterior semicircular canal. This is the ossicular chain, incus, malleus, and the stapes. This is a round window. This is the cochlea. This is the tympanic membrane which has been reflected. This is the muscle of the malleus. The three bones, I will not go into the details of this. Facial nerve has 6 segments. One is the internal auditory canal segment, the labyrinthine segment, the tympanic, mastoid, retroparotid, and the parotid segment. I go from outside inside the temporal bone. The stylar process is the most important landmark in the neck for the facial nerve. The facial nerve is always posterolateral to the stylar process. You see, this is the stylar process here. This is the facial nerve. The stylomastoid foramen exists posterolateral to the stylar process, and this is the mastoid segment of the facial nerve. The facial nerve obviously has terminal branches, which we are not really concerned as of today. Now, this is the base of the skull. This is the digastric ridge, which houses the digastric muscle, and then the facial nerve, as you see, is posterolateral to the stylar process. This is the jugular foramen. And then you see that this is the neural component of the jugular foramen. This is the internal carotid artery. This is the petrous portion of the temporal bone. Now, as you do a mastoidectomy, how do you identify the facial bone, the facial nerve? One of the most important landmarks is the digastric ridge, and then the lateral semicircular canal. The facial nerve will be a millimeter or two just below or medial to the digastric ridge, and goes all the way inferior to the lateral semicircular canal. So it will be in this line from here to here, and once you drill in that direction parallel to the nerve, you have to find the facial nerve. now I come to the anatomy of this area. The posterior canal wall has been taken down. This is the lateral semicircular canal. This is the body of the incus, the malleus, the stapes, the region of the oval window, the facial nerve, the pyramidal eminence, the chorda tympani, the insertion of the muscle or the tendon of the malleus at the cochleariform process, that is the supramalleolar fold, and that's the region of the round window, the promontory. That's in fact the Jacobson's nerve, if it's if it's clear, I'm really not sure, and that's the area of the hypotympanum. So coming back to the posterior tympanotomy, you see after widening the sentinel cell as you come down, you obviously identify the facial nerve and the chorda tympani. It's not always necessary to isolate the facial nerve. You see the pyramid as the first structure, and then the round window and the incudostapedial joint. But if you look at this anatomy here, you see that this is an endoscopic anatomy of the sinus tympani. You see that from the pyramid, once you do a facial recess tympanotomy here, you first see the pyramid, and then you see the ponticulus, which is a small piece of bone, a shelf of bone between the promontory and between the pyramid and the promontory, and inferior to the ponticulus is the sinus tympani, and just under that is a subiculum. So this is an anatomy which is important. So when you're coming from laterally, this is the opposite here. If you're doing a posterior tympanotomy here, another structure that comes into play is the caudal crest. So you follow the caudal crest, the pyramidal eminence, the ponticulus, promontory, and the sinus tympani. I would like to show you the relationship of the carotid to the cochlea. You see that this is the round window, this is the cochlea, and you see this is the carotid, this is the promontory, this is the ascending portion of the vertical portion of the petrous internal carotid artery, the genu, and later on the horizontal portion of the petrous carotid artery. That's the area of the hypotympanum. The jugular bulb can be close to the facial to the promontory, and just can come to lie just under the facial nerve, thereby giving the surgeon a hard job. Otherwise it can stay away. There are different orientations of the jugular bulb to the cochlea and the facial nerve. This is a favorable situation, but this is not. So one has to bear in mind the jugular bulb's anatomy while performing a cochlear implant. These are the ampullary ends of the superior canal, the ampullary end of the lateral canal. This is the non-ampullary end of the lateral canal. This is the ampullary end of the posterior canal. The posterior canal non-ampullary end fuses with the non-ampullary end of the superior canal to form the common crus, and they get into the vestibule. So once you get into the vestibule, there is a structure that comes out of the vestibule, which is the endolymphatic duct and the endolymphatic sac, which lies under the dura of the posterior cranial fossa. This is the sac, and this is the lateral wall of the sac, the medial wall of the sac, which lies on the dura of the posterior cranial fossa. As I told you, this is the subarcuate artery. This is a small branch from the ICA, which is the anterior inferior cerebral artery, which perforates the arch of the superior semicircular canal. This is the area of the geniculate ganglion. We will not get into these areas for the lack of time, and I guess I'll go into the history, which is this is the labyrinthine section of the facial nerve, and this is the internal aortic canal section of the facial nerve. Now coming on to the internal aortic canal, this is the area of the Bill's bar. This is the cochlea. You see the cochlear nerve coming out of the cochlea, the modulus of the cochlea. The facial nerve lies superior to it. The superior and the inferior vestibular nerves have been reflected laterally to expose the cochlea. These are intracranial structures which we are really not going to deal with today. Brief note on the history of cochlear implantation. It's very interesting to know that an Italian by the name of Alessandro Volta was the first person to in fact stimulate the cochlea using an electric current, and that marks the beginning of the history of cochlear implant. This was in the early 1800s. And in the 1950s, Giorno and Ayres, French physicians, in fact did the first cochlear implant, but very unintentionally. They didn't really think about this as a science, but it was obviously House and the neurosurgeon by the name of Doyle, and then Simmons and other people who really, Simmons from Stanford and Simmons, they were a group from Stanford who really came out with the implant, which was then taken up by all other groups across the world, predominantly from the US and Australia, and obviously a couple of centers from Europe as well, to come out with all the implant companies that we know today. So Alessandro Volta, he used 2 metal rods in his ear with a 50-volt current, and he described that there was a boom sound within his head, followed by a sound that was like a boiling soup. Weaver and Bray eventually formed electrical, they proved that and in another patient they did a middle cranial fossa approach in 1961, but it was unfortunate that Doyle, the neurosurgeon, and House parted ways, and Doyle said that he's not going to part with the implant, so House had to start all over again. Meanwhile, Simmons and White from Stanford University actually put a 6-channel electrode implant much before House did, but it was House who, with another mechanical engineer called Jack Urban, in 1973, who patented the first cochlear implant, and it was commercially marketed as 3M, but it was still a single electrode implant. House and Urban also went on to implant the first child in 1973 at the age of 5 years. Graham Clark has to be mentioned in the history of cochlear implants, because he was the guy from who did a lot of work simultaneously when House was doing his studies. He published a lot of papers, and he came up with this with his cochlear implant, which was completely a different phenomenon from the House implant. He did his own work, and he implanted his first patient called Rod Saunders, and this led to the formation of the company called COCHLEA. These were the implants. You see how big the speech processes were. This was how speech testing was done after implant way back in the 1970s, and you see that this was the first speech processor, and you see how big it was. It was practically like a machine that had to be carried by the patient, and this was how it was. The eventual fallout of cochlear implant was also that this led William House to come out with the auditory brainstem implant in 1979. The last slide here talks about the trends in candidacy. We have seen a lot of changes as far as indications are concerned, right way back from the 70s to today. You see that the age of implantation has increased. The age of implantation has decreased right up to 12 months. Onset of hearing loss, in the beginning you see that it was just postlingual, then postlingual adults, pre-postlingual children. Now we have pre-postlingual, both adults and children, and various other indications. In fact, the scope of cochlear implant has expanded, and we find ourselves in a situation where we have more and more indications today, and I'm sure this will continue in the near future. Thank you for your attention.